In this video, we are going to talk about disorders associated with esophagus. In this part, mainly we are going to talk about esophageal motility disorders. So we have a patient who presented with dysphagia. So what exactly is dysphagia? Dysphagia is defined as the subjective awareness of difficulty in swallowing or perception of food bolus by the patient as it passes through the esophagus. Almost all patients with esophageal pathology will have dysphagia. Therefore, dysphagia is a very non-descriptive term that can result from any problem right from the oral cavity to the proximal part of the stomach. So why is it important? Dysphagia is associated with significant morbidity and mortality, especially in the elderly group of population. And subsequently, it can lead to complications such as dehydration, weight loss, and aspiration. Before we understand the pathology, we should at least know the basics of physiology as it helps us to understand the pathology in a better way. Swallowing is a complex activity which occurs in a coordinated manner. Why? To transport food, the ingested food, from the oral cavity into the stomach. Now, it mainly consists of three stages, that is the oral, pharyngeal, and esophageal. Among these three, oral is the only stage which is under voluntary control. The rest two are under involuntary control. So, in the sagittal section of the diagram, we can see the food bolus, which is depicted in the pink violet color, which is present in the oral cavity. This is the hard palate. The posterior one is the soft palate. This is the tongue. This is the base of the tongue. This is the mandible. This is the hyoid. This is the mylohyoid muscle. Here we can see the epiglottis. So this is the nasopharynx, which is leading into oropharynx and the laryngopharynx. Anteriorly going into trachea and posteriorly it is going to the esophagus, which is collapsed in this image. So basically, after eating, the food is chewed and moistened with saliva. When the food enters into the oral cavity, there is initiation of the oral stage, which mainly occurs due to contraction of the tongue and striated muscles of the mastication. Now, in the oral phase, there is, as depicted in the image, there is posterior movement of the tongue. Why? To mainly prevent the food bolus going anteriorly back into the oral cavity and cause regurgitation. And there is also cranial movement of the soft palate as depicted in this image so as to prevent nasal regurgitation. Once the food has left the oral cavity, it is no longer under the voluntary control. When the food reaches the pharynx and it touches the posterior pharyngeal wall, it leads to the activation of local sensory receptors, which initiate the deglutition reflex. Now, the deglutition reflex is a centrally mediated reflex, which is mainly a wave of inhibition. And this reflex must be very well coordinated simply because, the pharynx is the common channel for both trachea and esophagus. So, in order to prevent aspiration, it has to be coordinated perfectly. When the food bolus reaches much below, there is upward movement and anterior movement of the larynx with downward movement of the epiglottis, basically to prevent aspiration into the trachea. When the food reaches into the esophagus, there is simultaneous relaxation of the upper esophageal sphincter, including the cricopharyngeus muscle, which is usually present at C6, C7 level. Now, when the food enters into the esophageal stage, peristaltic contractions occur of the smooth muscle of the thoracic esophagus. It basically propels the food towards the lower esophageal sphincter and stomach and subsequent relaxation of the lower esophageal sphincter, which persists until the bolus is propelled into the stomach. Now, esophageal peristalsis mainly consists of three waves: the primary wave, the secondary, and the tertiary. Primary and secondary waves are always physiological. Tertiary wave can be physiological or pathological. Primary wave and secondary wave, they go in single fashion from the cranial to caudal direction. Simply because of the fact that there are two types of muscles in the esophagus: outer longitudinal muscle and inner circular muscle. In primary and secondary waves, there is contraction of the longitudinal muscle, which propels the food, and there is relaxation of the circular muscles, which leads to relaxation of the sphincter. So there is downward movement, which makes sense. However, in tertiary waves, there is simultaneous contraction of both outer longitudinal and inner circular muscles. Therefore, it is non-propulsive. Therefore, the food bolus doesn't move anywhere. There's vigorous contraction of esophagus. And now talking about sphincters, there is an upper esophageal sphincter and lower esophageal sphincter. Upper esophageal sphincter is usually present at the level of C6, C7, which is mainly responsible for swallowing reflex. Lower esophageal sphincter is mainly is present at the gastroesophageal junction for gastroesophageal reflex. The main thing what you have to remember is that the upper esophageal sphincter is anatomical, that it is mainly formed by the circular muscles, whereas the lower esophageal sphincter is physiological. Why is it important? Since the upper esophageal sphincter is anatomical, the pressure which present at this location is much higher compared to the lower esophageal sphincter because it is physiological. This is the table demonstrating the differences between the upper esophageal sphincter and lower esophageal sphincter. Upper esophageal sphincter is mainly innervated by the vagus nerve and glossopharyngeal nerve, whereas lower esophageal sphincter is innervated by the vagus nerve under the autonomic nervous system. So, when a patient comes with dysphagia, how do we evaluate the patient? First, we have to take a plain film. In many cases like achalasia, it can be diagnosed even on plain film. Then barium swallow, or we can go for video fluoroscopic swallow, which is the modified barium swallow. It can also be depicted in endoscopy, manometry, and cross-sectional studies such as CT and MR. So the esophageal motility disorders has been classified based on the Chicago classification, which is the latest one is the version 4. It is mainly based upon the high resolution manometry values, which is the investigation of choice for esophageal motility disorders. So there are 3 parameters assessed. These terms look complicated, but they are very much self-explanatory and simple. So to make it as simple as possible, see, the first one is the IRP, which is the integrated relaxation pressure. It is the pressure which is present at the lower esophageal sphincter over a specified period of time during which it should relax the lower esophageal sphincter so as to allow the passage of food bolus. Right. However, in certain conditions like achalasia, there is failure of the lower esophageal sphincter to relax, which leads to elevated pressure in the lower esophageal sphincter, which is nothing but the elevated IRP. Normally, it should be less than 15 millimeters of mercury. Greater than 15 indicates pathology. Now, the second entity is the DCI, which is the distal contractile integral. DCI is a numerical value which represents the strength and duration of contraction. Contraction where? In the lower esophagus. So it basically tells us with how much strength the muscle is contracting. If the value is low, it means the contraction power is low. That is a weak contraction, seen in conditions like ineffective esophageal motility. If the value is high, that is excessively strong contraction. It may be seen in conditions like diffuse esophageal spasm and hypercontractile esophagus. Normally, it should be less than 8,000 millimeters of mercury. If it is greater than 8,000, it indicates hypercontractile esophagus or the nutcracker. Now, the third parameter is the distal latency. Again, the term is self-explanatory. Latency. Latency means that it is the time. It is a time taken for the peristaltic wave to move from upper part of the esophagus to the lower part of the esophagus. So basically, time taken for the peristaltic wave to travel throughout the esophagus. The time it should take is from now usually 4.5 to 6 seconds. If it is less than that, it means that there are too many frequent contractions, which is seen in conditions like diffuse esophageal spasm, or if it is too slow, that is more than 6 seconds, then it indicates that there are delayed contractions. So these are the graphical representation of the manometry findings. Here we can see the upper part, the red one, the horizontal line, it represents the upper esophageal sphincter. Here the red means high pressure and the blue one means is low pressure. As already discussed, upper esophageal sphincter is anatomical sphincter, therefore usually is present in high pressure zone. So it is present in red area, which is usually around 120 to 140 millimeters of mercury. Whereas the lower esophageal sphincter is a physiological sphincter. Therefore, it is present in the, since it is a physiological sphincter, it is a low pressure zone. Right. Here we can see that upper esophageal sphincter is contracted. There is minimal lower esophageal sphincter is mainly relaxed, and we can see the lower thoracic part of the esophagus is showing peristaltic contractions as depicted over here. So motility disorders of esophagus mainly can be divided based on whether it is affecting the esophagogastric junction or not. If it is, so the disorders can be the disorders which are affecting the esophagogastric outflow, and the others which are affecting the peristalsis. Now, the disorders of EGJ outflow include the achalasia and esophagogastric outflow obstruction. Disorders of peristalsis basically includes the peristalsis can be absent or it can be ineffective or sometimes it can be way too much, which is seen in diffuse esophageal spasm and hypercontractile esophagus. So talking about achalasia cardia, basically we have two nerve plexus in the esophagus. There's a superficial plexus, there's a deep plexus. Superficial plexus is present in the submucosa and it is called as the Meissner's plexus, which is responsible for secretions. Whereas the deeper one is the myoenteric plexus or the auroblack plexus, which is responsible for motility. So the main problem occurring in achalasia is that the deeper one, the myoenteric auroblack plexus, there's a pathology in it which causes the which obviously we know that it is responsible for motility. So since there is a pathology in it, it obviously explains the fact that there is loss of primary esophageal contractions in it. Along with that, there is loss of lower esophageal sphincter, therefore indicating that there is lower esophageal sphincter pressure is higher at resting level. Which basically is represented in high resolution manometry as integrated relaxation pressure IRP, which we already talked about. So since there is no relaxation of the lower esophageal sphincter, it is obvious that the IRP is elevated, which is above greater than 15 millimeters of mercury in achalasia. Usually seen in 30 to 50-year-old population, patient present with dysphagia, initially at least liquids more than solids. It can be treated with pharmacotherapy such as nitrates, calcium channel blockers, pneumatic dilatation, and surgical myotomy. So in this plain radiograph, we can clearly see of the chest X-ray, we can clearly see the esophagus is grossly dilated, and there we can also see few air fluid levels. One air fluid level is present over here. The gastric bubble is also, however, present. These findings, along with presentation, is a classic for achalasia. We can also see that the bilateral lung fields are normal. In general, in plain film, in the lateral view, sometimes we can see the anterior displacement bowing of the trachea due to bulging of the trachea. You can also see there is rightward movement of the trachea, probably mainly due to the esophagus. Sometimes even patchy alveolar opacities can be seen in bilateral lung fields, indicating acute pneumonitis or chronic aspiration pneumonia, which is related to dysphagia. A barium swallow study may be used to confirm the esophageal dilatation and for assessing mucosal abnormalities. Now, in this image, we can see there is dilated esophagus with contrast hold up. There is stasis where tapering is occurring at the lower esophageal sphincter and narrowing seen at the junction, which gives a characteristic bird beak appearance or the rat tail appearance. Now, what you have to remember is that it is essential that the patient with achalasia is examined in recumbent position also, because sometimes in erect position, gravity can simulate the effect of peristalsis and hide certain abnormalities. Since obviously there is holdup of contrast in patients in achalasia, timed barium swallow should be performed. In this CT coronal image, contrast enhanced CT, we can see the esophagus is grossly dilated with food residue within, involved from the cervical esophagus down till the gastroesophageal junction where it is tapering. Patients with uncomplicated achalasia demonstrated dilated thin-filled esophagus. Overall, CT has little role in assessing patients with achalasia, but it is useful especially to assess complications. Careful assessment of the esophagus should be undertaken to identify any focal regions of thickening along the wall, which may indicate malignancy. As we know that achalasia can lead to malignancy. And obviously, lung should also be inspected to check for aspiration. So in this high resolution manometric graphical representation, here clearly we can see there is in this is the area of esophagus. There is no red thing, which indicates that there is no pressure, there is no contraction, there is complete absence of peristaltic waves. And since the lower esophageal sphincter is a physiological sphincter, even green and orange also indicates high resting pressure. All these features are consistent with achalasia cardia. Now the second entity is the diffuse esophageal spasm. Basically over here, there is loss of primary peristalsis with simultaneous, spontaneous, repetitive, and these repetitive contractions are non-peristaltic and completely uncoordinated. This can be seen easy on manometry, and in these cases, lower esophageal sphincter is usually normal, basically indicating that the IRP is normal. So if the IRP is elevated, first we think of is esophagogastric junction, which includes achalasia and outflow tract obstruction. Here, IRP will be normal. However, since there is uncoordinated, too much contraction of the esophagus, there will be elevated distal contractile integral. However, the classic feature of diffuse esophageal spasm is that too frequent contractions in too less time. That is, the contractions are occurring, and that the time taken for the contraction to move from the upper part of the esophagus to the lower part of the esophagus is less than 4.5 seconds. That it is moving way too fast. Now, here in this barium swallow image, the oblique view, we can see uncoordinated peristalsis, and there is simultaneous contractions of the esophagus at multiple points, which is giving us a corkscrew appearance or the rosary bead appearance. What we have to remember is that only 60% of patients with barium swallow done in these cases will be abnormal. 40% will be completely normal. And in less than 5% will show the classical corkscrew appearance or rosary bead appearance. Non-peristaltic contractions, which push the contrast in two directions, towards the oral cavity and towards the stomach, sometimes may be the only feature which is present. Sometimes this also gives the appearance of sacculations or pseudo-diverticulum. In this graphical representation of manometry, here we can see there are too frequent contractions which are occurring way too frequently in too little time, indicating the low latency, which is important to diagnose the diffuse esophageal spasm. The third entity is the hypercontractile esophagus. Here mainly there is loss of primary peristalsis with simultaneous, spontaneous, same repetitive, non-peristaltic, uncoordinated contraction. But the thing over here is that the contractions are occurring at very high pressures. So since the lower esophageal is usually normal in this case, IRP is normal usually. Since there's too much contraction, the distal contractile integral is elevated and it is greater than 8,000 millimeters of mercury in hypercontractile esophagus. Here, in this high resolution manometry graphical representation, we can see strong, high spasmodic contractions involving the lower part of the thoracic esophagus. Hence, it is named as hypercontractile esophagus or the nutcracker esophagus. So this is the summary table. Clearly, we can see first we have to look for integrated relaxation pressure. If it is greater than 15 millimeters of mercury, it means that it is affecting the esophagogastric junction, and it can be achalasia or EGGO. Based on the involvement, achalasia can be divided into three types: type 1, type 2, and type 3. If the integrated relaxation pressure is less than 15 millimeters of mercury, it will be disorders of the peristalsis. And if the DCI is also low, it can be complete absence of contractility, which can be seen in scleroderma. Or if the distal latency is less than 4.5 seconds, that it is way too frequent contraction seen in diffuse esophageal spasm with classical corkscrew appearance. And in hypertensive peristalsis, which is the hypercontractile esophagus, the distal contractile integral is way too much. It is much more than 8,000 millimeters of mercury. Thank you.